Hi, everyone. Thank you for joining the School-Based Health Alliance for today's webinar, Developing and Implementing Tele-Behavioral Health in School-Based Health Centers. COVID-19 has driven rapid adoption and acceleration of tele-behavioral health services in school-based health centers. In this panel discussion, behavioral healthcare providers and administrators will describe their experiences implementing or adapting tele-behavioral health programs, identify challenges and opportunities discovered through this process, and discuss strategies and best practices for others moving forward. The School-Based Health Alliance works to improve the health of children and youth by advancing and advocating for school-based healthcare. We believe that all children and adolescents deserve to thrive, but too many struggle because they lack access to healthcare services. School-based healthcare is the solution, bringing healthcare to where students spend the majority of their time, in school. When health and education come together, great things happen. Attendance improves, conditions like asthma or diabetes are better managed, and behavioral health issues get quick expert attention. And we all know that healthy students make better learners. Now, we have a few housekeeping reminders. All attendees are in listen-only mode. However, we want to hear your questions. To ask a question at any point during the webinar, please use the Q&A tool located in your Zoom control bar. We will address questions following the presentation. At the end of this webinar, attendees will be asked to complete evaluation poll questions. Please let us know how we are doing. Your feedback is vital in helping us craft presentations that meet your needs. This webinar is being recorded and will be archived on our website in 1 to 3 business days. Please also visit the School-Based Health Alliance website for additional archived webinars for topics such as the ones you are viewing on your screen. Now, I would like to introduce our presenters for today. Santoy Latifa Trotter is the School-Based Behavioral Health Program Manager at UCSF Benioff Children's Hospital in Oakland, California. And Lee Forte is an art therapist, behavioral health clinician, and the Regional Clinical Director at Community Health Incorporated in East Haven, Connecticut. Now, I'll hand it over to Katie Stinchfield, a Senior Program Manager here at the School-Based Health Alliance, to begin our panel discussion.
Thank you so much, Maddie, and welcome to Lee and Santoy. We really appreciate you joining us today. So this is going to be a pretty casual format. We'll just ask some questions and let our expert panelists share their experiences. So first off, if you guys could just tell us a little bit about where you work and where you're from, and then describe how you adapted behavioral health service delivery using telehealth to meet student needs since COVID-19. We'll start with Santoy on this one.
Thank you, Katie. It's wonderful to be here with everyone. I wanted to share, just to root us in, school-based health centers are a strategy towards building health equity through location and collaboration. So I work at 2 school-based health clinics located in East and West Oakland, California. We're a federally qualified school-based health clinic within a hospital system. And our school-based health clinics, as many of your school-based health clinics, have medical primary care, confidential reproductive health care, health education, and behavioral health care. And our behavioral health team consists of MFTs, LCSWs, psychiatric nurse practitioners, so we are able to prescribe and assess for medication, as well as trainees. We are actually welcoming our trainees today. It's their first day, and so excited to train the next, the workforce. One of the strategies we've had to provide telehealth or services remotely is by maintaining that deep collaboration with our school partners. And so that means we have a weekly coordination of services team meetings that have continued during the spring when school went remote, even during the summer, and as well as maintaining relationship with school administrators and leaders as we're working with them to think about how to innovate and meet the needs of students during this time, as well as identifying who are our most vulnerable students. We were fortunate being part of a hospital system that we already had the infrastructure to be able to have HIPAA compliant Zoom. And so we're able to pivot to telehealth. I know that many of our partners and friends who have school-based health centers, part of that was having to build up that infrastructure. And so we are fortunate to have that already to be able to provide services. And also medical and electronic medical records that had that capacity as well. But we still needed to address many of the widening disparities, especially in terms of access to technology. in our communities. And so, you know, not everybody has a computer. Many families are sharing a phone. Also, not every family had privacy. Many of our families are doubled up or living together. Families were afraid to go outside, especially at the beginning of this pandemic. So those are some of the things we had to troubleshoot. You know, using WhatsApp, sometimes using FaceTime, and knowing, you know, for a period of time that those were allowed, you know, by the BBS. We also maintain connection with young people in any way possible. And again, especially at the beginning through text, phone, you know, having those light touches to really support young people to have that connection with their therapist. And that was really important at the beginning, and to meeting them, you know, even if they were in bed, again, at the beginning of this, and not getting out and watching video, kind of Zoom, really knowing that those behaviors were coping strategies, ways that they were surviving. And so meeting them wherever they're at, working with their parent and their caregiver as well. We had, you know, a lot more intense family therapy and collaboration with families. And I think one other thing I will share is that families, that our therapists and clinicians also found ways to innovate, including dropping off food or dropping off therapy supplies, you know, thinking about what they might have in their office, creating kits and dropping those off to families. Also doing DoorDash with food was another strategy that a therapist did, and said, okay, you know, I'm going to send you this food and then let's have it together, just to get them to the camera, to the Zoom. So those are some ways that people innovated. And one thing that we've seen is a little bit more consistency, and especially with some of our family work. We had a therapist who spoke about her family work and having a caregiver who lived in one home, a child who is currently in foster care, and a child welfare worker. And actually, there was an increased consistency in their family meetings as they're planning towards reunification, being able to have everybody come together through Zoom. So those are just a few ways. I look forward to hearing from Lee and to sharing a little bit more, but that's just an introduction to some of our services at this time.
Thank you so much, Santoy. That's awesome. And Lee, same question. A little bit about where you're from and where you work, and describing how you adapted your behavioral health services to meet student needs via telehealth.
Sure. I apologize ahead of time if I'm a little froggy. I'm getting over a great sinus thing. I think I've been sick with everything but COVID this summer, so bear with me. I am in Connecticut, and I work for Community Health Center, Inc. Connecticut is one of the 3 smallest states in the country, but we got a lot of people. So Community Health Center has standalone clinics. We are federally health qualified clinics, and we have school-based health centers that are comprehensive and behavioral health only throughout the state of Connecticut. Lots and lots of school-based health centers, over 200 in the state alone. I oversee, I started overseeing the shoreline of Connecticut, which would go from Stamford to Groton. And with our growth, I've been able to condense more towards the town that I'm working out of, East Haven, and New Haven, and the remote towns closest to me as we've expanded. What I do personally is I am an art therapist and a clinician, and I'm also a clinical director for my team. I oversee other licensed professional behavioral health clinicians in their schools, and I help troubleshoot all of the problems that they have, clinical and logistical and etc. CHC provides us with a great team to support us. We have senior leadership prepared to, you know, address any difficulty that has come our way during the COVID time, as well as program managers who handle the logistics of cleaning supplies and masks and how do we get everybody behind protective barriers and such. We also have a great team of in-office remote workers that help us connect, as Santoy was saying, via telephone and text and anything and everything we can think of to make sure that clients have access to us and can reach out to us when and however we need to do. The transition has been interesting because I have been notorious in my company for running an art therapy program out of my school. Every year we do an art show in conjunction with the school district. Every child in the entire school district has a piece of art that they're able to put on display. And the kids that are in my art therapy program are able to confidentially display the various art that they have been able to make. And we usually have a curriculum throughout the year that shows their growth, emotional and mental health growth, sometimes through poetry, sometimes through art they make, with explanations. And we also allow viewers to write comments. Everybody gets a number so that they can receive comments from the viewers and get pumped up usually, and a lot of credit for the work that they've done through their expressive communication. So I've been known for that. That's a program that I've developed in Connecticut. Obviously with COVID, that put a little bit of a damper on something like that. So we were lucky. I had a great group of kids that were willing to reach out and do Zoom groups. And so what that meant was I had to get creative in my home, and I had to have kind of a Bob Ross situation where I had one camera pointed on the work I was doing, one camera pointed on me, and then they worked on their own medium that they had available to them. And we did weekly themes as art therapists do, directives, and then we also allowed for branching out and doing more personal expressive. But the other great thing about the groups was that we allowed each child the opportunity to socialize, which, as you can imagine, has been greatly reduced. So a lot of the clinicians that work under me and CHC, and especially within my art program, socialization and venting frustrations and anxiety, all of that has been our key focus as well as behavioral health clinicians. A lot of the anxieties these kids have, being in school, being in public, being away from parents at times, lessened actually with some of the COVID stuff. New anxieties took their place. So the ability to get together over Zoom allowed them to voice their concerns and feel supported by that. And we were able to do that on a pretty consistent basis. So I don't know if there's anything else specifically I can talk about, but CHC as a whole is very committed to reaching out to clients that don't have means as well. We have delivered supplies, masks, troubleshooted technological difficulties. My company has even been willing, starting this year, to possibly deliver art supplies to continue the artwork that some of the students are doing with me. So I've been very grateful for their support.
Fantastic, Lee. Thank you so much. So I'll move on to our next question. And maybe we'll start with, let's start with Santoy again, give Lee a little break. If you can talk a little bit about the challenges and opportunities that have arisen from this experience.
Absolutely, thank you. We all know that schools are a protective factor for students, and for many students and adults on campus, right? It's a refuge, it's a sanctuary, it's a place where students go for caring relationships. And one of the challenges is that we've noticed that, vulnerable students have become more vulnerable, more isolated. There's been a heightened amount of acuity, heightened amount of suicidal behaviors. We had a young person have a suicide attempt the first week of shelter in place in March. We've had more suicidal behaviors, in the past 4 months than we've had in the past 4 years. So I think that definitely has been a challenge, and I'm grateful for the team of therapists that I work with and their skill and intuition and partnering with family members to support young people to be safe, having to interpret sometimes a vague text and contacting a family member to have them check in on a young person to see if they were okay, and if they weren't, connecting with emergency services. So that's been a challenge. And one of the ways we've met that challenge is by increasing our case review we have a consistent case consultation, but adding in some additional, some additional clinical expertise, as well as a specific case consultation for high-risk cases to really think together, have a focus thinking about what's needed during this time. And so I can think that's been the biggest challenge, as well as thinking through support for the therapists. That therapists are now isolated. It used to be like, oh, I could pop into someone's office and debrief or share about the day, the amount of trauma that they're holding, and being isolated during this time, thinking about ways that we can, keep thinking about how do we support. We had a summer retreat, had to do it doing via Zoom, really wanted to meet in person in the park, but just decided it was safe to do it via Zoom, but finding ways to support that connection. I think, we already spoke to the challenge around just technology, access to technology, phone bills being paid. We're fortunate our district has distributed Chromebooks and has redistributed them now that school has started. Actually in Oakland, we're in our second week of school, but still many, really paying attention to how do we bridge that gap. I think a challenge and an opportunity has been around, we are, you're in my home right now. Welcome, everyone. We are in our clients and our students' homes. And for some young people, there's a lot of, I don't know if I want my therapist in my house. I don't know if I want my teacher in my house, in my room to see. And so, and for some, it's like, oh, here's my house, here's my home, here's my environment, right? So it can create some closeness or some kind of more information in the work. And so I think that is both a challenge and opportunity. And some ways of working about, especially in individual therapy, is giving as much choice as possible. So whether people have their cameras on or have their camera off or have their camera on and maybe you're doing therapy like this and you just see one eye, right? I just need to see one eye. So really giving a lot of choices and opportunities. We were able to launch a virtual or pilot a virtual dialectical behavioral therapy group. We had been working to do that in the spring and had just gotten the group together. And then COVID hit, right? And so we had to re-recruit I hear that maybe the audio is breaking up, so I'll put earphones on, but that we had to re-recruit and ended up doing a DBT group virtually. And with 2 therapists, having one therapist be able to monitor the chats, support the group while the other is facilitating. And I think one last thing is, having, using the opportunity of Zoom to support, both the therapy, but also another layer of being able to engage young people in coping strategies. So let's look at this yoga class together. Let's do this mindfulness together. Let's watch, share screen capacity to do that. Let's, some students didn't get to go on their college tours. So let's do a virtual college tour of the colleges that you're interested in. So really using that share screen aspect, show and tell. So those are, some of the opportunities that we're finding. I think sometimes having more consistency in terms of people showing up for treatment because all they have to do is click that link on their phone. And in other ways, definitely some challenges, especially around the gap, the technology gap.
So many great examples, Santoy. That was great. And love hearing about some of the opportunities. I know it's hard to stay focused on the positives sometimes right now. And it's great to see some of the adaptations we can make that really are beneficial. And also thank you for honoring the work of so many of our providers and our parents and our teachers and all of the community via our work with youth that are also pivoting and adapting all the time. All right, Lee, your turn to talk a bit about both challenges and opportunities that you've seen come out of this experience.
Well, I agree that we should stay solution focused and try to, highlight opportunity, because I think that's what's going to keep us moving forward in this craziness, is to focus on what we can do and what we can't, and not what we can't do. But I do echo what Santoy said about being in the homes. That has been a blessing to be able to see things that were missing before. I was, before in a previous life, a long-term in-home therapist. So that was a huge piece that I really appreciated, being able to piece together the differential and everything that I was dealing with. And it also helps us get connected with our clients because we see what they struggle with. But I also agree that there was the flip where I had clients pointing the stuff at the ceiling because they didn't want to be seen, having just woken up or whatever, despite me not caring. The other opportunities, what I'll start with and say is to be able to be flexible. I have not realized how flexible I can be in doing this work. So getting creative, I love being creative in general, but being even more creative. And I know that you shared the news link, so you get to see, if anybody's interested in looking at that, some of the students' artwork and their expressions of what it felt like to do an art therapy Zoom group. So it made them feel good that they can share that. They had a lot of self-esteem built from that. There were some additional interviews that came from that. So just from that one small subset alone, I think that that's a great win in terms of what we can do with this media. Other opportunities, I think Santoy also said, the families can be more involved, and whether this is something that was a complication versus a positive, the parents need more help. It's been evident beyond belief that the parents need more help. I myself am also a parent of 3 young school-age children. I need help. So it's been really good to have the parents. A lot of times in school-based health centers, they kind of sign them up, drop them off, and especially if you got teenagers you're working with, you don't see the parents all the time. This has given us much more opportunity to talk on the phone with parents, to hear grievances, to get more kind of an insight into how they're seeing their children, and that's been a gift. The other thing that I've absolutely adored is that we've been able to provide social outlets. I talked a little bit about this before, but a lot of the groups or the sessions, even if it's just a pairing of two people that have worked together previously or know each other in schools and have that comfortability, they've been able to use that time to express themselves, talk to each other. It's not the same when they have FaceTime with their friends. There's something about having a clinician present for that sharing of information that makes them feel heard. It makes them, feel that they're not being judged for the things that they're struggling with. And even if we're just playing games and casually talking, I've seen a huge benefit. And this media has allowed us to do that. So that's a gift. The challenges, unfortunately, there are some. Burnout. Burnout is real. We do not have, when I'm working, I hold the physical space with my clients. That's a huge asset to the work that I do with them, my physical presence. I don't have that on a computer screen as easily. So engaging them, keeping them engaged, especially the younger kids who want to run around the room and, whichever, is difficult. And a lot of times there isn't privacy, or there isn't an easy way to give them that physical presence that they need to get through something that's difficult. This is a challenge that we're going to have to figure out how to deal with as clinicians, that without draining ourselves and our batteries. Engaging in this medium is a great gift, but the work we do isn't inherent to doing this. So we have to come up with ways to remain engaged and to remain healthy with care. I think overall, though, having access to things glitching, phone calls being able to be made when we need to, we've really stepped up and shown how resilient we can be, not only as providers throughout the country, but as clients. The people who need the help have access to the help, and we're working our butts off to make sure that you do. And I applaud everybody, because this is not easy work.
I echo Lee's sentiments. Our panelists and all our providers listening in, it is difficult, and we appreciate so much the work you're doing. And Lee, I liked what you were sort of saying about, I think when I think of technology and virtual therapy and those things, I really think of, historical bias feels isolating to me, but you really highlighted ways that it's actually, we're sort of able to personalize and connect more, especially, with both clients, students, and their families, which I think is lovely. So I'm going to go to our last prepared question now, and then we'll open it up to, we're getting lots of questions from our attendees. So back to Santoy, if you could just discuss some strategies and best practices that other providers and organizations who are adapting to telebehavioral health service delivery might benefit from, that would be great.
Yeah, absolutely. I think just to remind us all that some of the best practices for face-to-face are the best practices for telehealth. So having a structured way that you begin a session and end a session. So that, there is that shift into like, okay, now we're in session. So whether we, begin with 3 breaths and kind of have a grounding, have a way that we review to check out whatever your practice is, but that there's a structure, that, a way of beginning and ending a session, that we're still engaging our evidence-based practices. So for us, DBT, CBT, as well as engaging trauma-informed practices, cultural humility, and accountability. So I just wanted to kind of frame that. Paying attention to therapist well-being, as we spoke about, consistent consultation, consistent supervision, and having ways for therapists to connect, as well as being clear who does that therapist contact for consultation if there's a crisis. We did have an intake work group. So there's one thing to continue with the clients that you already have a relationship with, but as the months went on, we need to reopen back up and take in new referrals. School is going to start. So we brought together, within our system, a group of providers, admin staff, supervisors to think together around how are we going to do intakes. And I'll share a few things that came out of that group. One is to be able to safety plan for every client, so that every client does have some sort of emergency number, or family or caregiver has, what they do in terms of emergency, even if there aren't safety issues present. We need to have a face-to-face session, video session to confirm a diagnosis if we're doing an assessment. So if someone's shy about the phone, we at least definitely have to have one face-to-face. I spoke earlier about our case review for high-risk cases to provide that additional support and thought partnership for our clinicians. That we're documenting telehealth in every note and that has to happen consistently, as well as screening for the impact of stress of COVID-19. And some of our programs, one of our early intervention services created a COVID-19 screening tool for families. We also want to introduce and orient family members, clients to the end-to-end video platform. So, you know, just as we've all, like now, I think we've got it, everybody probably logged on, all right? But it's like, okay, here's the mute, here's the camera. You can hide yourself from camera, speaker view, gallery view, you know, just having that, not just making assumptions, making sure you're orienting everyone. As well as, so I saw a question around consent. So what we have, you know, at the beginning, people were mailing consent forms, knowing and documenting that, knowing that there'd be probably a slow return on those consent packages. Our packages are we're part of Alameda County Behavioral Health, very long, very thick. And then some therapists were door dashing consent forms. So dropping them off to family members, waiting for them to sign it, grabbing it. And now we're using DocuSign for most of our consents, but that was a process of gathering all the consent forms, putting it all in. That's what our work group worked on, being able to troubleshoot some of the things that might come up with families receiving the DocuSign, making sure we're sending it in some ways that had a code to keep it confidential. So we're mostly using DocuSign. I can talk more about that if people have questions. And I think those were, kind of some of the primary kind of best practices, I think, in terms of intake, assessment, consents. For our informing materials, we use DocuSigns, but we need to have it a screen share so that we're viewing it together so that there's a witness for that signature for informed consent, for sharing information. So those are a few things. I'll pass it to Lee and see if more comes up.
Yes, and I love, I know there have been lots of questions about consent, so yeah, feel free to, attendees feel free to ask more if Santoy didn't cover your specific question, but that was a great dive into that tricky issue, and I definitely appreciate Santoy. I know those of us who work in school-based health are used to being creative about how to create solutions for students and their families, and I think that was a great example of, you know, we can't do our consents in person, so here are the various ways that we're going to adapt. We're not just going to give up, but we're going to find these different ways to get it done. Love that. Okay, so Lee, same question, strategies and best practices that other providers and organizations adapting to telehealth could benefit from.
Okay, so strategies, very similar. Our senior leadership meets every day at 11 o'clock to troubleshoot. Connecticut has not gone back to school yet. Most of us are starting on the 1st or the 8th. So I know that there'll be some last minute kind of adjustments to you know, because every county in the town is doing something slightly different. Not everybody's on the same page, which makes troubleshooting difficult for us. But we are also moving towards DocuSign. In the past, we were able to do verbal visual communication to get the go-ahead. Our state agency allowed that to be enough until we had some, you know, mechanism to be able to do it in a formal way. So we had that leniency and we were grateful for it. In terms of what we've been doing for best practices, we have a subset. My company was very intent on not having to lay off any of our support staff during the COVID-19. So all of those staff were able to rally together and in essence, switch up their positions to be able to help clinicians schedule, confirm appointments, keep things moving. So that was a huge help to the clinicians, and I'm certain that that will continue to be a help as we move into the school year. We've also partnered with our schools, so the clinicians have reached out and been able to sit down with either committees via the school or the town, just to make sure we're aware of what the towns and schools needs are, as well as what ours are and what we can do to kind of troubleshoot to make a seamless, you know, start or ongoing start-stop, depending on what this year looks like for us. We honestly, my personal best practice and what I tell my clinicians is make sure your clients know what they're going to be doing when they sign on with you. If they're doing an art therapy session, they should know that. If they're doing a socialization game session, they should know that. If they're doing a personal processing session or a family session, there shouldn't be as best as you can, surprises. They should be prepared for whatever it is we're going to do. And there should be obviously an emergency plan for everyone, considering the fact that we don't have that physical space so maybe some questions that, we can just run through each session. You're doing okay? If I'm being annoying or redundant, that's fine. Tell me so. I just want to check in with you and make sure. So we've employed some of that. And also just kind of giving the clients the kind of code word to say, this is what I need from you right now, and meeting them where there is. I think even though it's important to have those things set up and their expectations, to manage anxiety addressed, they also have to have the right to say, this is what I need right now, and what can, how do we help? So being flexible, best practices, I think just having the client's best interest. I mean, what else can we do? We have to make sure that they have the support they need while we're also supported. And I'm going to love to hear all the creative things I'm sure everybody has to offer on this subject as well.
That's awesome. Yeah, and I know both you and Santoy mentioned sort of having an emergency plan because we're not meeting in person. So really thinking through what would the next steps be for each and every client if something big happens, or if we need to do some safety planning and prevention work. I think that's very important, obviously. And then also I liked how you were sort of talking about, as therapists, we think a lot about the physical space of our office or our school classroom, wherever we're working, trying to make it comfortable and accessible, and a place that our clients feel safe and respected. And it was great hearing some of the ways that you're doing that via Zoom. We can still do that virtually, and not surprising folks, making sure they're comfortable. Santo, you mentioned, making sure people know how to use the technology. Very basic, but could create a lot of anxiety.
I think the one other thing I would add, just as a shout out to clinicians that if you have been doing it or you haven't been doing it, setting appropriate boundaries too. We want to meet them where they are, but I did have one client one time have their mother talk to me while she was in the shower. So it was important it's important to have a conversation up front about where it would be appropriate to have a session and who's around and, that kind of thing. So I hung up on that session and rescheduled for that one because Mom was shouting over the shower curtain. So that's my other little shout out. Just make sure everybody knows what's appropriate to engage telehealth.
Yeah. Perfect. Yeah. Also, yeah, parameters around the safe space. I like it. I've heard a few of those stories lately. So I know that both of you already, Santo, you talked a bit about consent. I don't know, Lee, we do have a lot of questions about consent and, HIPAA compliant technologies. Do either of you have anything that you'd like to share more specifically about how to obtain consent and or how to make sure that your telehealth options are HIPAA compliant?
We have a team of lawyers that make sure what we are in compliance with what the state regulates. So I really defer to them, and they give us trainings as often as something changes in terms of what we can offer, what we can allow, and how we document. So I would just encourage everybody to follow up with your legal department, and if you don't have one of those, find someone who has access to that kind of information in your state, because that way you'll be covered.
And similarly, that that the state and the Board of Behavioral Health Services, that at least initially that there was some leeway for being able to have end-to-end video. There were some requirements around end-to-end video, but it didn't only have to be the HIPAA compliant Zoom. But to paying attention that you're working with the regulation of your state. Again, I said we were fortunate because we had that, but not every family had that. So there was still some families who chose to engage via WhatsApp, right, instead of via Zoom, because that's what they had access to. But you want to definitely be in compliance.
Yes, absolutely. And I know, again, shout out to both of our panelists, to the field at large. I know everyone's adapting. And so I think that as this continues, we'll have more tools and resources really specific to HIPAA compliance via telehealth. We're hearing lots about it, and I'm sure that as soon as we have any of those tools, we'll definitely share them too. So feel free to reach out to the Alliance as we work.
I also just wanted to add that I think, at the early end, we all heard, and even at like kind of the horror stories around Zoom bombing, and students heard that as well. And we had a young person who, middle schooler is very anxious about being on Zoom because of what she had heard about and what might happen. So really validating, acknowledging that, what would you do if something happened? Again, if you have you want to go with the highest security possible to avoid that. We also have now passwords for every session, for every meeting, that there's a password to try to avoid that. But really acknowledging the impact of that and the stories that students have heard.
And then it sounds like, I think you both have mentioned too, offering other options if they prefer to meet via phone or other ways to connect that might feel more comfortable or private. I think that can be helpful too. Santoy, we're getting lots of questions about, you mentioned a COVID screening tool, and folks are asking about that, wondering how it works and if you would share it.
Yes, I pulled it up. I thought I might get questions about that. And I need to really credit Barbara Ivins and our early intervention specialist team, because they are the ones who created it and adapted it. I think it is a family stress screener, and I will ask her if I can share it out. I can do a quick screen share if you'd like here, but I can, or just speak to it, ask questions around like your child's, on a scale of 1 to 5, strongly disagree to strongly agree, because of COVID-19 related stress events and changes I've felt increased stress about, and it asks about my child's schooling, child's feelings or behaviors, understanding the new coronavirus and how to keep my family safe, experiencing racism, not having enough food, losing a job or income, housings or utility, loss of limited childcare, parenting children, tension or conflict between household members, and there's immigration status, loss of social connection, reminder of past stressful traumatic events, increased anxiety or depression, physical health concerns, and tension or conflict between household members. I can see if we can share that out.
Yeah, that's wonderful. For us, our APRNs and medical staff do that. So they screen everybody that comes in through medical to make sure that nobody that needs access to behavioral health is missing, so that we have that kind of avenue. And then we create a portal for clinicians to go and claim, people who need support and offer them support on the spot. But that's a great screening tool.
Yeah, that was awesome, Sandra. And I think that would be interesting over time to see how those responses, not only on the client level in order to support folks, but also globally for your client caseload. It'll be interesting to see how people respond and continue to respond over time. I know we have tons of questions. We've got over 50 questions now from our attendees, so we're going to do our best to answer them. If we don't get to everything today, I know you can always reach out to me. I can pass things on to Lee or Santoy, and we can also get you contact information for them if they're willing. We've seen a bunch of questions about engagement. So not only, continuing to engage clients that are already enrolled, staying consistent with appointments, but also engaging new clients in this this virtual environment. Either one of you want to take that one?
Yeah, I kind of am grateful that I had the in-home experience of the past, because in that kind of capacity, you have about a minute to make a first impression and have them accept you into their home or kick you out. So what I would encourage people to really kind of get comfortable with is your initial presentation, your face, your warmth as much as you can have over this kind of media. Don't be afraid to be humorous. It's always an awkward kind of situation when you're initially meeting somebody. Be warm, be understanding, be personal. That's rapport. You want to be able to build that rapport as soon as possible with anybody that's new, even to therapy in general. We're getting a lot of people who are new to therapy because now they can access it over the phone or over the Zoom, whereas they could never do it before. So there's a whole subset of people, which is also one of the wonderful things, that are getting first-time touches where they didn't have it before or had fallen off. So rapport.
And I would agree with all that Lee said. And I think the only thing I would add is, we work with adolescents, so giving lots of choices, and we work as a team. So it's, we are in contact with the school. If a young person is referred, we're speaking to them, ideally also speaking to their family, and then giving them options, right? So you're doing all that, you engage, and really remembering that, with the Zoom, like, got to be a little bit more, bring it a little bit more lively, but also giving choices and assessing, right? So we have a clinician just yesterday was talking about a young person had a traumatic incident that happened last school year, was referred for therapy, primary care provider referred, parent referred. Young person's very open in the conversation, but said they're not interested right now. They feel safe because they're not returning to school. And so my advice for the clinician was to consult, with the parent. How's their functioning? Are they sleeping? Are they eating? Are they engaging in school virtually? If they're doing okay, just the most important thing is that the mom sought out help for her, and to let the young person know that the help is here when they're ready. But it's also okay that they don't need to engage right now, right? And if they're not, then we're going to work harder to work with the parent, work with the school, make sure there's a good clinician match. Bring in, we don't have to talk about the traumatic thing, but really do all the things that we would do in a school to engage young people who, it used to be that we would go to their door, right? A teacher would refer, we'd get the referral, meet them on campus and like, hi, you were referred to therapy, right? And even there, they'd be like, who are you? What's this? What does this mean? What's therapy? And so we're just still using those engagement, giving people choices. I have one young person, a 13-year-old, who, parents are requiring therapy. And so our work is around, the same work that you do with anyone who's mandated. We're voluntary, but your parents are requiring this. How do we find what works for you? And that we're not that's our conversation, right? And using scaling questions, using yes and no questions, right? 13-year-old boy, less verbal than my 20-year-old girl clients, right? And so scaling questions and really giving lots of different options that lower the anxiety to support having shorter sessions. We're going to do 30-minute sessions instead of 50-minute sessions, providing choices.
Those are great tips. Love hearing that. I think it's really heartening to hear all the ways that you guys have found to connect and build that rapport and keep young people engaged. Totally agree. We've got some questions about screening. Do you screen for suicidality at every session or only when you see warning signs? And maybe we could talk a bit about what that might look like virtually. And then what do you use to screen or inform the safety plan and intervention?
We have standard assessments that we use, but I was saying before that with certain clients, it may be worth coming up with a certain set of questions, and you can even make it, if it doesn't seem prevalent and you still should ask them, you can make it funny and say, okay, I got to ask these questions, just to kind of make sure you're touching everything, especially if they're in a higher risk bucket. In terms of screening, that's part of the emergency protocol too. So for individual clients, so if you have somebody that's at risk of certain behaviors, self-harm, suicidality, that you have the supports in place and the processes in place and whatever, so that way if you get concerned or if they fall off or if you're not, you're not able to get a read over, that you're able to follow through with something like that. So it is as needed, but it's good to have that already kind of plan set in motion to be able to use at a moment's notice. Yeah.
Thanks, Lee.
And I think for us, definitely we screen for suicide as part of our assessment. And then safety plan, of course, have a safety plan in the treatment plan, in the electronic medical record. If the young person is indicating suicidal thoughts or ideation. We use the LRAMP, so that's through DBT, Marsha Linehan, as part of our kind of decision-making tree. And especially right now, right, we're working towards, I'm glad someone brought up the question about suicide, because we're trying to keep people out of the hospital even more, right? Generally, like as a clinical stance, we are trying to treat people with suicidal behaviors with the least level of containment possible, right? And to keep them in their natural environment. And right now, there's a risk going to the hospital. And of course, if someone needs to go, we will facilitate that. But we also want to even more so work with their environment when possible. We did have our county actually invested in a mobile crisis unit that used to only work, kind of was very limited in terms of their scope, and they've brought in their scope and they've received some training to work with students, knowing that schools are going to be remote. I think we've also used the Columbia rating scale as well. And I don't think we assess with every client, every session, but we do use our assessment and continue to assess for safety and risk. in our treatment, and especially if it's indicated there's ever been any sort of suicidal thoughts or behaviors, or any history of suicide in the young person's family or environment.
And I would just encourage everybody to continue to talk about the plan, because you don't want to just make a plan at jump and then file it away in an electronic record somewhere and then not be engaging with it, because the plan that worked in March may not work in August anymore. So not that it has to be the focus of every session, especially if they're doing well and they're not symptomatic that way, but just revisit it and have conversations. Let it not be the elephant in the room, so that if ever you do need to use it, that you can address it easily and people are on board with it and they're not resistant. And so I would just keep it a fluid topic as needed.
I like that. I like specific clinical tools, obviously using those evidence-based tools, and then also clinical judgment, and then also just making it a comfortable conversation, part of that emergency planning. Yep, I love it.
I think if I'd add one other thing, I think that's where our high-risk consultation has come in, and also determining, if there's a higher level of care that's needed, and being able to refer to some of our county mental health services if there's higher level. When we're on campus, I think given the coordination and the collaboration, we had more capacity to support those students, and they had more, again, more protective factors around them. And now really making those more difficult decisions of, we may need to transition this young person to another level of care, if given what their level of suicidality and acuity and behaviors.
No, that's a great point. And actually referral was another question that came up, but I think that's a great point in terms of really, how do we continue getting referrals when teachers aren't in school seeing students? So how do we continue that communication and referral to the school-based health providers? And then also, Santoy, it sounds like being really thoughtful about how we refer and what constitutes a referral now in this climate.
One thing that we've been doing in our work with the schools collaborating is the superintendents and the principals, or even the support staff, have communications that they send to the families. So we are included in all of those communications, ways to access us, whether they're the gatekeeper or whether they come directly through CHC for services. So we make sure that they're getting all of the information. Or basically, what the communication is, anybody that needs help is able to get help. Insured, non-citizen, if you need help, we're going to help you. So the families can feel. And then we also have family aid workers through the towns that we work in that have joined with clinicians so that they do more outreach, whether they're door dashing or contacting because they have the relationships with the families, suggesting, hey, there's these other resources and supports. Our medical providers are doing PQH9 assessments to rule out anybody that is coming in for medical reasons that may also need to talk to a clinician. So we have a lot of tentacles out to make sure people are aware of how to access us.
I just want to add to that, kind of coming to my first point, is that school-based health is location and collaboration, right? That two-part. And to really when this first happened, March 13th, it's like, okay, how do we reimagine school-based health? And it's not just our location, our proximity. You could have a clinic on a school campus and nobody goes. Right. And so it is that collaboration that we've, just as Lee spoke to, that we've continued, meeting with teachers. We presented school, they came back last week, we were there. We did a PD on trauma-informed teaching during COVID-19 and the Black Lives Matter movement, right? How do you build, Oakland decided to do a strong start, which really the first 2 weeks were focused on relationship and social emotional well-being, community building. So we coach the teachers on how do you build community within your classroom? What are the things that you're going to be looking out for if you need to refer to a mental health referral? That we are not in this work alone, but it really does take that deep collaboration and partnership with our schools, whether we're all on campus or remote, that we're maintaining those relationships to best support young people and their families.
Thank you so much, Santoy. That is one of my very favorite soapboxes, that so much of what we do is related to that collaboration.
Mm-hmm.
And I loved what you had to say. I know our President Robert has said many times that schools didn't close, the buildings closed.
Mm-hmm.
School is still happening in a very, very rich, diverse way. And I think that that's so important, that collaboration, that foundation with with the school. It's so telling now. If you have that, you can do so much via, you know, several folks on the attendee list and our panelists have mentioned the ways that schools are reaching out to students and teachers are reaching out to students. And if you have that strong collaboration and communication, you can continue accessing them. Lee, did you want to add to that?
No, I love everything she said. You know, I think us stepping out of our clinical role and doing PDs for the teachers, you know, most teachers aren't trained in the social emotional stuff. So, you know, where they would normally struggle, there's still struggles and plus 10. So anything that you can do for your school systems to be present in the rooms and in whatever safe way is possible to, you know, talk about or help navigate, I think that that's a great gift, not only to the teachers in the school, but the community, the children, and the families. So I definitely love that. Great work.
And I have another question to kind of follow up on that one. I know we're getting near the end of our time. As I said, we got way more questions than we could ever answer. No surprise there. If your question didn't get answered at the end of our presentation, Maddie will share contact info. You're welcome to email me. We can circle back and try to get some of those questions answered. The one I would sort of like to wrap up with, we received one where someone asked if how do you work through compassion fatigue, guilt over things you didn't think of in the moment, or as we're adapting to technology and virtual care, how do we take care of ourselves as well as we learn?
I can tell you one thing that I do, whether it's on Zoom or not, I do this in my practice as well. A lot of times what happens is we reflect. Something happens in the moment. If it's not a crisis, right? We handle crises in the moment. We go back and we reflect. So what I love to do, and what especially my adults through my kids love to hear, is I say something like, I was thinking about you the other day and what you said the last time. And you know what? I think I figured something out. Because you're also modeling for them what you want them to do, which is to be reflective, and to not just disregard every thought and feeling that they're having that's uncomfortable. Like, sorry about my hound. And so they feel so special, I think, when you can prove that you have care and thought about them beyond what they're saying to you. They're not just a number, a client, an obligation, but somebody you're actually considering and really invested in helping. So that's something that I do that has been very well received. I'll let Sanjoy.
Yeah, this is a question I sit deeply with for the past, 20 years, right, doing this work, and even more so now. I think there's, both self-care and collective care. And, as we're stewarding trauma, to take Laura Lipsky's work, right, trauma stewardship, that we are responsible for our self-care, right? So, gardening, stepping outside, right now, every morning, I'm like, let me just sit outside, listen to the wind and the trees and take a moment before my day begins. And for our team and for our clinicians, I'm noticing increased impact of the stress and trauma, as I spoke about in terms of isolation. And so having times, I love what you said about reflective practices. Remember, we need that, not to just be reactive, but to have those times to reflect, to have that consistency of supervision, to be able to have times that we do gather to celebrate one another. Life is still happening. We have a baby shower that happens, that's going to happen on Friday. We've also had deaths and loss on our team. People have lost family members. And so that we come together to grieve, we come together to celebrate. We start our consultations with some mindfulness, breathing, grounding. I think some people are like, oh, okay, you gotta do the grounding, but it's like, no, we're gonna do the grounding. And then, we alternate doing that. And once someone does, it's like, oh, okay, that there is a positive benefit there to just we have our parasympathetic, sympathetic nervous system. And so that we need to come together to regulate that, one thing I've learned as a supervisor also, because I'm a little bit of a glass half full person, is to also validate the pain and the difficulty that people are holding right now, right? You want to speak to that? Because it's like, we got this, we're good, we got this. And to really also hold like, this is a really hard time.
Yes, and it's funny because I also, as a supervisor, I have built in vent time, because I'm also, let's be solution focused. Let's not get swept away in the pit that could be despairing. There's no hope for us there. There's no help for us there. But I'd rather have you venting to me and each other than, to your husband or to a client. So we schedule venting sessions, and I've even done groups for some of my older kids that can kind of really appreciate appropriate venting. Just to be able to say whatever you want in whatever language you want, and just kind of have that support and validate, and have even their supervisors say, you're right, this really sucks, and whatever. And now, all right, now we're going to go out and do what we got to do. So just to be human, just to be human. And my other advice is, each clinician, get reflective about what you can handle and what your boundaries are, and come to know that, so that you can communicate to your leadership, this is what I can do. I know what I have to do. I know the climate is changing, but this is how I can provide the best care possible. So knowing your personal boundaries is huge in this climate. This was fun.
Both so much. We so appreciate your expertise here. And again, such rich discussion, so many wonderful tips. I am so sad that we couldn't get to all of the questions. I'll definitely send some your way if there's time to respond to those later on. And I know Maddie will share contact information for the Alliance so that we can follow up with anyone that has further questions or concerns that weren't addressed today. Again, thank you so much, Lee and Santoy. This was fabulous. So much rich content. We really appreciate your time.
Thank you, Katie. Thank you, Santoy.
Yeah, thank you, Lee. Thank you, the Alliance. And just thank you to every therapist out there, being a lifeline and a support for students and families at this time. We really appreciate you.
Yeah, we're in awe of what you do. Thank you.
Thank you, Santoy and Lee and Katie, and everyone for joining us today. I just launched the evaluation poll questions. If you could just take a minute of your time to answer those, to just give us some feedback.